Good morning, ladies and gentlemen. Great pleasure to have all of you with from India and from all over the world for this webinar, which is being conducted with the support of Sun Pharma. Really appreciate their help, and with several of physicians who are leadership from SCAI. My co-moderator Timothy Henry, who's Master SCAI, is going to be online as well. And Tim, thank you very much. And we have a great panel here. From China, we have Professor Shaoliang Chen, and he is an international ambassador and for SCAI, as well as he's the vice president of Nanjing First Hospital in Nanjing. And as you know very well, he is the master of all the DK crushed trials for left main bifurcations. Along with him, we have Imad Shaiban from Italy. He is the director of interventional cardiology and also has done a lot of work in India. I don't think he needs any introduction for our Indian colleagues. And then we have Parvez Miraj from New York, from Northwell Hospital. He is the director of interventional cardiology and director of CHIP CTO program at Northwell, as well as an associate professor from New York University, Northwell and Hofstra University. And with that, actually, we will be taking some questions. We also want you to make sure that you could address the questions as early as possible, so that in this next 1 hour, we will be able to address most of the questions regarding the COVID webinar from SCAI. So I know many of us have been really upset about how COVID has been turning our lives upside down, and it has affected many countries globally, and now it is hitting India quite hard, and we want to make sure that this webinar can help you in decision making for those patients who have acute coronary syndromes during the season. So with that, thank you very much. I introduce my moderator, Tim Henry, to say a few words, and then we will start our program.
Delighted to be here this morning. I think we have an outstanding panel that will give us really some experience from around the world. And I think we have really a good outline today of the things that we're going to cover, including the new SCAI document that just came out yesterday in the American College of Cardiology and CCI, the SCAI, American College of Cardiology, and American College of Emergency Room Physician guidance on acute myocardial infarction. I think there's a lot of important information to discuss there on how we take care of our acute MI patients. So welcome.
So thank you. And actually, I didn't introduce myself. I thought pretty much everybody might know me, but I'm Ramesh Dagubati. I'm a professor of medicine at West Virginia University and director of the structural heart disease program here. And so with that, as let's talk about the guidance, SCAI guidance document. Tim, you mentioned about how this document has come in. You're one of the main authors, along with Parvez and Shami Mahmood, who's our president of SCAI. Could you please enlighten us about the SCAI guidance document, and what was the purpose? What did you think that is being done appropriately, and what is not being done appropriately?
So first of all, I think maybe some background I think is worthwhile. So number one, as we look at COVID, that we know that patients who have underlying cardiovascular disease are at higher risk. And as you get older and cardiovascular disease, also diabetes, those patients are clearly at higher risk. So that's, I think, one important factor. The second important factor is that the coronavirus itself has direct cardiovascular manifestations that are important, including myocarditis, as well as a whole host of things, including patients can present with right ventricular failure, with cardiomyopathies, with arrhythmias. There's also procoagulant effects associated with this. So that I think one of the issues is, and obviously also just because of the situation, we're in a very stressful situation. And so the stress-related things in terms of plaque rupture, stress cardiomyopathy, spontaneous coronary artery dissection also would be expected to increase. So I think that we would have expected in this day to actually see increasing ST elevation, patients with ST elevation. But what we've seen is that there's actually been a decrease in STEMI coming to the hospitals really all around the world. That's true in the United States, it's true in Spain, true in Austria, all have been published. So I think one of the things you also note out there is that part of this whole syndrome is that patients are scared to come to the hospital. And I think that's a danger because as patients are scared to come to the hospital, then that creates a situation where people have a heart attack at home and present late. So what we try to do in the guideline is, as best as we can tell now, looking at all the data, and we can talk about this further, is I think what the overall summary of the guidelines is that we should treat people as best as we can, just how you normally would. So primary PCI is the preferred treatment for patients who have ST elevation. And I think it remains the preferred method of treatment, and if you can be done so safely. And it might be during this time that it takes a little moment to actually do rapid testing if it's available, do point of care ultrasound to look at the heart if it's available. But I think still our primary approach should be to do primary PCI and angiography. There was just a short series of 18 patients from the New York area, again, that we'll probably talk about more. But I think one of the take-home points of that was there was high mortality. About half of the patients didn't go to the Cath Lab at all. About half of the patients developed their ST elevation in the hospital. So clearly, presentation of ST elevation during the era of COVID is more complicated. But I think overall in the guidelines, and I think it would be good for people to read it and think about it, and then think about it in your practices. But overall, I'd say the summary of it is, as best as possible, treat people the way that we know is the best, which is primary PCI.
So it's a very fantastic overview, Tim. I think this is a new document that has just been released yesterday, published in both the JACC and the CCI. Is that correct?
Yes.
So, I mean, this is giving a guidance on how people who have PCI-capable hospitals and non-PCI-capable hospitals, and how actually people should receive from right away from ambulance or EMS down to taking them to the Cath Lab. And there's also a great discussion, as you can see in this picture on the PowerPoint slide, that patients who are from field, the ambulance or EMS brings them with a STEMI, and your COVID-19 status is unknown. Majority of them fall into this category, where we do a quick pit stop. That's what we do in our hospital as well. We call it a quick pit stop in the emergency room. The patient has to have a mask, which usually the ambulance people take care of that. And we do a very quick, focused HNP, mainly going towards the cardiology questions as a chest pain, shortness of breath, but at the same time, a 5-question questionnaire for COVID screening, shortness of breath, fever, and any weird symptoms, fatigue, malaise, cough, and cold, and as such. And I mean, obviously, we were asking about recent travel. I don't think that is going to be any of any pertinent importance right now. So if you want, you could still ask that. And based on ST elevations, then in COVID positive or probable, versus COVID possible, you decide whether the patient should be taken into a non-COVID-19 cath lab or a dedicated COVID-19 cath lab. Let me ask you here, Tim, and then I'll ask all the others. What is a dedicated COVID-19 cath lab?
Yeah, so what we've done, for an example, and I think, first of all, another really important point about the guidelines is that we had to be flexible enough, depending on where you are around the United States, around North America, and really around the world, because I think the resources at hospitals vary considerably, and the prevalence of the disease varies considerably. So I think all of these guidelines need to take into account where you are, what your availability is, and what the prevalence of the disease is in your locality. So that being said, so for example, in Ohio, in Cincinnati, we had a moderate number of cases. So I would say at the peak, maybe we had 60 to 75 patients in the hospital, including probably 30 to 35 patients on ventilators and 3 or 4 people on VV ECMO. So that would probably be where our peak, and then we've gone down from there a little bit. So I would call that a moderate amount in the United States. And what we did in that situation, so we typically have 4 labs that are used each day for coronary labs. And what we did is obviously we decreased our number of elective cases, but one lab we made a COVID either positive or high probability lab. And then the other 3 labs we tried to do to keep without COVID patients. And the rationale for that is when you take a positive COVID patient to that lab, then you have to spend a lot. Not only do you have to be careful from a personal protection standpoint, but you have to clean it. And so it takes longer to turn that lab around. And I think the other thing that we did in that lab is as much as possible, you can take disposables, everything out of the lab, so that you have the lab as bare bones as it can be, and you have availability to bring things into the lab. And then I think another general important thing is try to decrease the number of people in the room to only people that really need to be in the room, so that you decrease exposure. So those I think would be some of my general concepts about how you make a COVID lab. But I will also say it varies a lot, and I think we can probably talk with our panelists about that as well.
Yes. Let me bring on Xiaoliang Chen from China. Do you have negative pressure rooms in all your cath labs, or at least one of them now?
Yeah, actually, in my center, we have 4 cath labs, but we only have 1 cath lab with negative pressure. But in Wuhan, to be honest, I think there was no cath lab with negative pressure.
Okay. How about in Italy? Let's bring on Dr. Imad Shaiban.
In my hospital, we have 2 cath labs. One is COVID, and the other one is for non-COVID patients. But actually, we do not have that much pressure because we do not have that much emergencies now in this period. That means we have reduced STEMI patients.
So what if you have only one lab, and anyone could answer this, and how would you say that what precautions have to be taken? Would you want to convert that into a negative pressure room, or put a HEPA filter? What type of recommendations are you making now?
If you will stop doing completely elective patient, then you can dedicate that only cath lab for only emergencies. But this is, I would say, it's not possible to do if you have only one. Then I think that you have the sanitization every time after every procedure. You should do it. You should clean. You should, I mean, take care about sanitization every time you are doing a procedure with a highly probable exposure to COVID or positive, or any kind of emergency that you cannot be sure that patient is completely negative to virus.
Okay. Let's bring on Parvez from New York, a very busy hospital. The entire system of Northwell has seen probably the highest number of COVID positive acute coronary syndrome patients, or in terms of volume, you have the highest volume, I think. Let me ask you, how do you sanitize your cath lab?
So thanks for having me, and I agree. This has been a process from the very beginning. Been for over 6 weeks now. We've been trying to figure out our protocols, but we dedicated, just like everyone else has dedicated, a single cath lab to COVID patients. We have 5, so we dedicated 1, but we had the option of dedicating more. And as Shaolin said, that we were able to cancel all elective cases, which is the large number of cases. So our cath lab would typically do 50 cases a day. We went down to 1 or 2 cases a day. And in doing so, we were able to have the capacity to take care of these COVID positive patients. We had about 10,000 COVID positive patients that went through our system since the start of the epidemic. So it's not been a small number, and it's pretty much inundated the system. But cleaning the labs and cleaning the rooms has been a process. It's what we call a terminal clean. The terminal clean is essentially a process where everything is wiped down in the room, and exactly what Tim's, you said, that all the disposables were taken out of those rooms, because cleaning everything off is not an easy process. So everything was taped down, everything was plasticed away, so that didn't need to be uncovered, and we would wipe everything down. And at the end, there's also a UV light system that was used, that was done to clean out all the areas and try to make it as sanitary as possible. We unfortunately have an older vent systems in our cath lab, so none of our cath labs were able to be converted from a typical positive pressure to negative pressure room. So we had a HEPA filter at the door every time we had a patient come in.
And you have to probably wait 45 minutes to an hour before bringing another patient if you have only 1 room. Is that right?
It was long. It was longer than that, actually. It was probably the process of the terminal clean between patients could last up to two hours. Wow. So it's a very long process to actually clean these rooms down, and therefore anyone with only 1 cath lab, it becomes an issue. But as Imad said, the volume of ACS cases is not anywhere near what we used to see. We're a cath lab that would typically do 300 to 400 STEMIs, not including non-STEMIs, a year. Our volume is down over 50%, as we represented in the paper that Tim and I and all the others wrote, in terms of the volume that went down.
Mm-hmm. Parvez and Tim, just from the guidance document, a patient comes in, 60-year-old with a STEMI into the ED. How quickly can you make a decision? Is COVID probable or possible?
So that's also been evolving, right? Because I think at the very beginning, our testing in the United States, and again, this varies from country to country, but at the very beginning, it was taking us 6 or 7 days to get tests back. So basically, what a probable or positive, we were going by with classic chest X-ray findings or classic CT findings, and that there are some clearly patients that highly likely have that, and or the intubated patient with the classic chest X-ray or CT, I think we assumed was positive. And then there was patients who have, there's a lot of overlap between COVID symptoms and ischemic heart disease symptoms, quite frankly. And I think this has been one of the problems and confusing. And in fact, it's more of a problem for a coronary disease patient who might have had an infarct several days ago and now has heart failure and is not really recognized. People are so focused on COVID that they're not thinking about, ischemic heart disease. But now what happens is now we have very rapid testing so that we can have tests available within 1 hour. Still, though, I would say for acute myocardial infarction, that's still too long to wait. So what we do is, the ideal way is we do recommend everyone stops in the emergency department. So prior to this, in many parts of the United States, many parts of the world, we would have had paramedics activate the cath lab and go direct to the cath lab, or a relatively short stop. What we really recommended now is that you slow down a little bit, evaluate the patient, get an idea of the symptoms, get an idea if you can do testing, or get a chest x-ray or a point of care ultrasound. Again, that varies from institution to institution. And then look at the EKG. Is it diffuse ST changes or not? And take into account the symptoms, the EKG, whether it's focal or diffuse, and point of care ultrasound, whether there is a global, either normal LV function or global decrease, that would be less likely that this is STEMI. Or if you have the classic focal EKG changing with the focal wall motion abnormality, then that would be the patient that you think is really ST elevation. You want to go as quickly as possible for primary PCI. Now, I will say it's not perfect. And if someone wants to look at the EKGs that were actually published in the New England Journal, you will see that there's a fair amount of overlap with this. And so I think the background is we should treat people as if they're having a STEMI and go for primary PCI. And if they happen to have normal coronaries, then that's fine. But I think that's our general plan, but I'd be interested in the other panelists' thoughts about that approach.
So Shaolian, we were just talking a little bit earlier about whether my patient underwent COVID screening or not, COVID testing. What do you do now with all the patients coming in?
Yeah, actually, at the very early stage, I think a rapid PCR test was very confusing and very challenging because, the reliable rate was not high. I think it was below 70%. A second reason is that, a Chinese Society of Cardiology recommended routine chest CT scan. I think it's very important, particularly for STEMI patients with relative high temperature, probably around 72 or 72, 75 degrees. The third thing is that with the recovery of the virus of the patient, and then nowadays, all hospitalized patients have to be tested on the admission. And also, we tested the PCR and also measured antibodies for all medical staff. So I think these are very important for us.
Yes. How about you, Parvez? Do you think rapid testing is, with all its the sensitivity issues that it is having, how many patients are you doing rapid testing in New York?
So we in the very beginning of the pandemic, we obviously did not, just like anyone else in the United States, did not have access to any kind of rapid testing, and our testing actually took days to come back. So we created our protocols in the beginning based on that setup, and we pretty much, based on symptomatology or based on where they were, or contact tracing or what have you, we created the profile risk of the patient, whether they were COVID positive or negative. As the pandemic progressed and we would get access to more rapid testing, we also appreciated that, unfortunately, in our region, and this is very different regions, different countries have different experiences, but in our region, we started to notice that almost every patient in the hospital, or that was coming to the hospital, was COVID positive. Now, there were very few COVID negative patients, and that was just a trend of what was happening, including our ACS patients. And so even with rapid testing today, which still can take a little bit of time, and there's the false negative rate that's associated with it, which we obviously have to take into account. We've gone to a system where we pretty much assume everyone has COVID, and we take the precautions necessary for these patients, and we treat every patient as if they have COVID. And taking them to the cath lab if they have ACS, we treat them in the right way, as long as, just like you would take any other patient to the cath lab in an ACS STEMI setting, if they meet the criteria where their mortality from from treating the STEMI with primary PCI would be a benefit for the patient. If the patient is in distributive shock in the setting of their COVID pneumonia, then that patient's probably not going to benefit much from a STEMI primary PCI. So it's more the patient characteristics and how sick they are that would probably guide our therapy today. But in general, even today, we are treating every patient as if they have coronavirus. Ramesh, you're muted.
And this is actually to Tim. The SCAI guidance document does not endorse thrombolysis, but we have to understand in places like India, where or probably in West Virginia, with the rural areas where people have taken to an ambulance or even helicopters take a long time to come here. Do you think that there is still a role for pharmacoinvasive therapy for these patients who are coming into outreach hospitals?
Yeah, so there's been lots of discussion about lytic therapy, and I think just for background for people is I have developed a large STEMI system way back in Minneapolis that had out to 200 miles away. So we had like 35 sites or 200 miles away. So many of those sites were non-PCI hospitals that came, and if we were more than 60 miles away, we had part of our process would do a pharmacoinvasive approach, because these are hospitals very distant and would take, typically more than 120 minutes to get to the hospital. So in that population, we would give, and we happen to give half-dose lytics with clopidogrel, but so I'm used to a lytic strategy, but I would tell you, and that still is true if you are going to be more than 120 minutes to do primary PCI. So I think wherever you are in the world, this varies dramatically on what your availability is. If you're going to be greater than 120 minutes from onset of pain, then I think the recommendation is to give a lytic, have a lytic strategy. But what happened, and I think a lot of the discussion in the United States and Europe in particular was, because of COVID, even in PCI hospitals, should we go to a lytic strategy? And I think that's the confusing part. And I think pretty strongly on those of us that are on this document, think the answer to that is no. If you're in a PCI hospital, if you can be expected to get to PCI in less than 120 minutes, that's the preferred. And why? Because if you look at it, and again, the New England Journal paper that had 18 patients, it's a small cohort, but you will notice that more than half of those patients that did go to the Cath Lab had normal coronaries. So you had this concept of STEMI mimics. So whether it's myocarditis or stress cardiomyopathy, you have a situation where you're giving lytics, patient continues to have ST elevation anyway, and you end up in the Cath Lab anyway. So you give patient the risk of lytics, and you really didn't get any benefit. So I think that pretty clearly, if you're in a hospital that does primary PCI normally, you should continue to do primary PCI normally. So, Prues, don't you agree with that strategy?
Yes, I would agree with you. I think that I think we in the initial stages, we too were a little concerned, and I think it was a concern of exposure, and there was a certain fear of the unknown. And I think that's probably the best way to describe it. The fear of the unknown, I think, got us. And I think as we started taking care of these patients and understanding, and of course, needing the correct PPE, and that's a very important piece of it. Most obviously, not just for the physicians, but for the nurses, for the technicians in the room, and for all the transportation staff and everything else. There has to be the proper, appropriate PPE so that no one gets ill. That's the last thing we would want, to try to save one patient and have 6 people fall ill from coronavirus. That would not be the goal of this. However, once we've learned the processes and the appropriate ways of mitigating those risks, we were able to then appropriately take care of these patients. And I agree. I think looking at the patient and their risks on their own accord not just saying that they're COVID positive or negative. I think that's too black and white. There's a lot of gray, and I think that just like we know that a 95-year-old demented patient that is AAO times 1 is different than a 65-year-old mildly demented patient who's AAO times 3. They're two completely different patients, although they both carry a diagnosis of dementia. They're not the same patient.
Yeah. Right. Can you go, Eric, can you show a previous slide? Yes. So this is the SCAI guidance document in which actually SCAI does say that there is a role for fibrinolysis. We are not saying that it is not there for people who do not have capability of doing PCI. We also know and realize that the door to balloon times might be delayed, and we have to make sure that our staff and healthcare workers are given the utmost priority to make sure that they do not get infected. And I'm going to now switch gears towards the PPE, which actually Parvez brought it up. In patient selection that we have looked at, CT scan we talked about. Let me ask from first Xiaoliang. I think some of the slides are borrowed from China. There is first, let's look at this PPE and I'll ask for discussion. All cardiologists need to take proper protection, almost level 3 if you're going into the Cath Lab for COVID positive or probable patient. The questions from our audience are coming. Who is COVID probable and positive? If you're in where Parvez is, for example, everybody should be considered as probable. It's a hot spot with the highest number of COVID patients that are coming up. And the mortality in just one county where Long Island, Nassau County is more than 1,300. More than 14,000 deaths have happened in New York State. And really, New York City. And totaling in the state about more than 17,000 or so out of 40,000 plus deaths in the United States. So this is a hot spot. So everyone should be considered as probable or positive. If a patient comes to West Virginia, where our number of cases are lower, obviously that we consider everybody who's coming from a nursing home as a probable. Somebody coming from home is considered as possible. And we ask a quick questionnaire about, as I mentioned, fever, shortness of breath, cough, and recent travel or contact with somebody else who's heard of COVID. So those are the quick questionnaires that we ask. But you look at it, category 2 plus, it includes 2 face masks, 2 medical caps, 2 pairs of gloves, and 2 pairs of boots. All are disposable. And this is when you're going into a contaminated area. Category 3, that means if you're anesthesiologist or if you're doing an intubation or if you're a GI, you're doing endoscopic procedures, TEE, and this is in addition to all those 2 caps. Now you have to wear another extra cap, 1 more surgical gown, 1 more pair of gloves, 1 more pair of boots. And this is a category 3 situation that people are now seeing their umbilical bag and they're intubating the patient, doing a tracheostomy here. This is the intubation in Wuhan and the tracheostomy in Shanghai that is being done. Next slide. In the United States, this is my fellow putting a swan in a probable COVID patient. And you can go to the next slide. So here you can see the difference in China, Italy, and USA. Initially, this is how they were. And from there, we went to, in West Virginia, we went with cappers, and they're still, the neck is exposed, which is a complete no-no in China. So these are the category of PPEs that we have. And Xiaoliang, let me ask you, and then I'm coming to other countries as well. In India, we have a problem with actually PPE. In Pakistan, when physicians asked for PPE, they were beaten by the police and they were protesting to have PPE. So in a place like India, where we're having some issues with the PPE, as you see, we do not have the same gear as China does. That said, our government in India is making the PPE in quite short of time, and hopefully everybody will get it. If we do not have proper PPE, should we take a patient who is infarcting into the Cath Lab at the risk of our staff?
Yeah, I think, Ramesh, I think PPE are very, very important for our medical team. So, at the initial stage in Wuhan, almost 1,000 physicians were infected by virus. Also, my friend who is working in Union Hospital in Wuhan, he is an intervention cardiologist. He was infected too. Second point I'd like to say, if we have no proper PPE, I think we cannot initialize our medical team to do PCR in Cath Lab. That would be very dangerous. Second point, I think India is very close to China. So if you can provide the mailing address, so I can deliver some PPE to them, that's our responsibility, I think. Also, a few days ago, Pakistani friend told me almost 20 cardiologists were out of because of the virus infections. Also, for proper PCR in Cath Lab, I think not only for STEMI, but also for very severe SAS with unstable hemodynamics. So before that, we have to upgrade our PPE from category 2+ to category 3. So finally, I'd like to say, before any management or test for virus, we have to treat every patient as COVID-19 positive. I think this is very, very important for us.
Very good. Italy?
Thank you.
Thank you.
Well, I think we have the same concept as in China. I think if you don't have availability of protection, then you will be at high risk for take the infection by operators, and then this will cause a collapse for the health system. And so to be very sure about it, I think if you don't have availability of adequate protection in suspected patients or in positive patients, you should not do it. Do thrombolysis rather than PCI, but you cannot do intervention in these cases because the infection is very highly, you expose all people around you for infection as well, not only for yourself as operator, but all the context of society you are living with. So I think it is very important point. You should consider every patient as positive if you don't know exactly the history of this patient. And if you are in emergency, you should not lose time you cannot lose time for testing COVID. So you have to take him in the cath lab if you have availability for adequate protection every time.
Yes. For the audience, some of the questions are coming and I'll be answering as well. For transthoracic echoes, we normally ask the patients echo techs to wear N95 mask and gloves and a gown. And the EKGs are already that they use on COVID positive patients will be cleaned with 2,000% of chlorine solution, and so that they are sanitized completely. Parvez, let me ask you about the PPE, and why was there such a difference in the infection rates among healthcare workers in Italy versus in New York? So unmute your phone, Parvez.
Sorry about that. I cannot answer that directly. I can only suppose that probably in the very beginning of the pandemic, I think when the initial outbreak was occurring, I don't think people recognized that these patients existed, and that happened in New York as well. Most of our healthcare exposure occurred in the beginning, in the early days, when people were not adequately PPEing, and then we were not. There was a false assumption that you had to have a fever, a cough, or some sort of upper respiratory illness in order for you to get the illness. And I think that false supposition made a lot of institutional regulations about masks not really come out till later in the pandemic. And also, I think there was a huge lack of preparation in general, at least in the New York area in general, because I don't think anyone expected or had intended or planned that so many people would get infected, and the need for PPE would be so great. So our PPE reserves were completely annihilated within a week, and so we weren't able to even get N95 masks, let alone stage 2 and 3 PPE, which honestly, it would be a dream to see in New York. I don't think I've ever seen that in my hospital, let alone, I mean, the poor anesthesiologists and respiratory therapists are taking care of patients the same way we are, and essentially there's no positive pressure airway or head cover at all for these folks. And so all of us are essentially working with N95 mask, a surgical mask on top, a cap, a gown, a face shield. But as you said, it's absolutely not ideal nor perfect. But I can only imagine that in Italy, I think the healthcare workers were probably exposed prior to the realization that there was this significant numbers of COVID positive patients.
Yeah, actually, this happened in very intensive infection areas. That means only in North Italy, and that was because of unpreparation. That doctors were not prepared to deal with this kind of infection. Second, availability of protection, PPE equipments was not that much available, I mean, on the market at the beginning, because China was coming out from infection, and most of mask was provided by Chinese industries in Europe. And at that time, it was not available on the market.
Yes, very good.
So
actually.
this was one of the factors then.
Yeah. Very generous of Professor Xiaoliang Chen and my friend, who has also offered us to send PPE if need be. Thank you very much, Xiaoliang, for also doing that for India. Tim, let me ask you, as the incoming president in 2021 for SCAI, which stands for Society of Coronary Angiography and Intervention, do you think we need to mandate every cath lab to have a negative pressure facility?
Well, I think that's probably not realistic, but I think certainly as if we're doing it, that if you have at least one cath lab, that is, and if you're in the luxury of building new cath labs and you can do that, I think that would be certainly an advantage. I will say this for our cath lab and for what we do is what we use we have had adequate N95s. So we use one for example, if I'm in the lab all day, I use an N95. We assume everyone's positive. I do put a second mask over that, but more to keep the N95 claim, and then I otherwise just standard gown and gloves. And with that, fortunately for us, and we've had a modest number of patients, but we've had no cath lab patient or cath lab personnel become positive. So I think that's I think modest, but it's certainly not overdoing it. So, Pruitt, do you think that would be your situation as well?
So I think we did take it a little step further. We do exactly what you're saying. N95 covered with a surgical mask. We are wearing obviously gown, gloves, shoe covers, but we are also and caps obviously. But we're also using a face shield on top of that.
Yeah, we use a face shield too.
Yeah, just and that's pretty much the upper limit of PPE that we have available to us. Yeah. There's not much more available to us that we can use.
And do you think, but from a cath lab standpoint, do you feel like that's adequate?
It has seemed to be, based on anecdotal observational data from our own cath lab, ever since we started doing this. We've taken care of many COVID positive patients in our cath lab, and we've all been redeployed to the ICUs as well, many of us, and we've been taking care of patients that way as well, and with the same PPE. And we haven't had conversions of healthcare workers since the implementation of that protocol. Yeah. I think everything happened prior to that.
Yeah, I think it's a really important point, and I can't say 100%, but I will say this is. So this is certainly it's more aggressive than our previous, what we were doing in a cath lab, but it is modest and it's obtainable in really any cath lab. And I think that's an important, that should be a level of protection that every cath lab should have available. And at that level, it appears to be protective and adequate. At least that's what we think right now.
Okay, let's look at quickly. I think we have a lot to discuss in the next 14 minutes or so. The insights into non-STEMI, STEMI, and cardiogenic shock, as well as CPR. I would like to start from China. Xiaoliang, you can comment about how are you approaching people now who require cardiogenic shock and CPR.
Yeah, actually, I think we have very limited experience and knowledge about CPR for patients with COVID-19 positive. But I think we have discussed much more about the importance of donning of PPE. But I think dosing of PPE also very important. We have many suffering experience from whole China. For CPR, I personally prefer the routine use of goggles. I think it's good enough. Also, the precondition is that before any procedure, we have to make sure the correct differentiation of a patient with and without the COVID-19 patient positive. Is that correct?
That's good. Very good. Excellent. Show us the next slide of CPR. Okay, this is from American Heart Association. You can follow this step 1 to step 4. Perform essentially call 911, cover your own mouth, make sure you are protected before you go into the area, then make sure the patient's face is covered with a mask, and do hands-only CPR, and make sure you have on gloves, and wipe the gloves after that, again with hand sanitizer, or carefully remove those gloves, and use an AED as soon as it is available. Next slide, please. And there are good algorithms on how to don your PPE, start the CPR, rhythm is shockable, then shock them, asystole, then intubation. The intubation has to be done not by anybody. Now they are to be done only at our center by anesthesiologists or pulmonary and critical care attendings, not fellows at all. So next slide. You can see that again, if they're not responding, continue CPR. If the rhythm is shockable, shock them. If not, you continue. No signs of return. You can just maybe have to continue CPR for another 10 minutes or 12 minutes and declare mortality. So let me ask Parvez about 2 things. One, I know that there is a lot of issues, I think, in how aggressive should be doing CPR. Is it now still half an hour, or once the patient arrives in-house as well as outside? Let's talk about in-house patient. You're taking a patient and he arrives.
I think that's a simpler conversation to have about the in-house patient who is COVID positive. So someone who is COVID positive and arrests in the hospital. Unfortunately, our experience has not been good, and I'm sure that's been the experience of many centers around the world. The majority of these patients don't survive. It's a much more lethal situation than a normal patient that would be otherwise having a cardiac arrest from typical causes, whether it be metabolic or ischemic or what have you. These patients with COVID, unfortunately, when they arrest, they're usually in the throes of their cytokine storm, and they're usually in the throes of horrible ARDS. And to get these patients back is not so easy. So we don't have an official time limit. That we have a policy. There's no policy. We do it on a case-by-case basis. And we look at the patient and how long they've been intubated for, what their age is, what their comorbidities are. And we've created a service in the hospital, actually, that every single patient prior to their intubation, even if it's in the emergency room, there's a conversation with the patient and the family over the phone or over a video conference or what have you, to have the conversation about what the goals of care are. Because the goals of care are so important. And also, we were so stretched to our capacity in the hospital Other places may not have this issue, but we were well over 175% of capacity of the hospital. So we normally have 900 beds in the hospital. We were running a hospital that was almost 1,400 beds, and triple the size of our ICUs. So given that capacity issue, we clearly had to make decisions as to how to appropriately manage patients in the best way that they could be managed. So cardiac arrest patients were obviously, they were coded. CPR was performed if the right patient was deemed to be salvageable. If the patient wasn't deemed to be salvageable, we knew that in advance of their code, hopefully, and we had that conversation with the family and the healthcare proxy to hopefully make them DNR. So that was our policy and procedure. It was by no means perfect, but we tried our best to try to sift out the right patient to perform CPR. And also one important point, to perform CPR if you're already intubated, is to not disconnect them from the vent and not open the circuit. We kept them on the vent, and we did manual bagging essentially on the vent to keep the circuit closed, because that's the safest way to prevent exposure to your staff and to yourself.
So let me ask you, Tim, how about giving a mechanical support, the Impella ECMO?
Yeah. So first of all, let me echo. I think that several of the other comments that Pervez made. I think it really does, depending on your own institution, and I think that for patients who are intubated and or on VV ECMO, for example, I think it's really important that you have a general strategy of how you're going to approach that. We were modestly busy, but never overwhelmed busy. So we actually had the luxury of, our real ICU doctors and pulmonary, the normal were actually taking care of people just like they normally would. And so, and had the ability to talk to patients and families and made decisions. And I will also say that, this is the disease that actually is really hard on, especially elderly patients and patients with underlying lung and cardiovascular disease. So a lot of the patients that we had that came in that were really ill were either very elderly or under. So a lot of those decisions that we made with families to start with. So I do think that's a really important point, that to be thinking about the family and the patient and what the goals of care are. So that's the second. In terms of mechanical support, I will tell you, I think there's mixed on terms of how successful it is. So, for example, now I would say that my experience now, after talking to lots of people, if you're done in a system that's not overwhelmed and you have patients who are not doing well with intubation, actually there's a fair amount of success with VV ECMO. We've had 4 patients that went on VV ECMO. All 4 did well and have come off and are extubated and out of the hospital, 3 of them. So I think, our experience for selected patients is it's effective. In regards to mechanical support, a lot of that for the COVID positive patient comes from when they have the cytokine storm and are hypertensive. And I think the experience with mechanical support in that patient population has been disappointing for sure, and not a lot of patients have survived. But I think another really, really, really important issue is this. When you're dealing with coronary patients in the COVID era, this concept of late presenting STEMIs, so these are non-COVID patients, and we've had just in the last 10 days, we've had 3 people that came to the hospital with late presenting STEMIs who ended up being put on an Impella and actually did very well. And I think there's a fair number of cases like that. So I think you have to be careful that we certainly start with thinking everybody's COVID, but you have to also remember that everyone's not COVID and that we have to take care of just normal coronary artery disease patients and heart failure patients that would present anyway. And if anything, we're seeing that there's this the problem of patients are scared to come to the hospital, and so therefore they come late after their infarct. So the reason why there's been this reduction in STEMI is because we've scared patients. And we need to encourage patients when they have chest pain and shortness of breath to come to the hospital, that we can care for them safely. But that's a long answer, but I do think it's complicated. And so I think that mechanical support for selected patients can be successful.
Yes, very good.
I think it should be based on case-by-case evaluation. I mean, it's not, you cannot create rules when to use it. And I totally agree with the delay that patients sometimes COVID negative are coming to the hospital hours and hours later after symptoms starting. So that is another big problem, because they are coming and you have to be very, quick in deciding what to do with these patients, because they are coming because they are becoming symptomatic more and more in heart failure patient. I think in this kind of patient, systemic mechanical support will be very useful. But in the meantime, I mean, if you are using that in COVID positive patient, then you are exposed for more infection coming with the catheters staying in the patient for more than 24 hours or 48 hours. So I think it is a very big challenge when you have this kind of patient, and every time should be evaluated case by case. That means the benefit should be very evident to use it.
So absolutely. I think the risk of not able to recognize patient is going to hurt us in people who do not have such a high incidence of COVID. People are dying in the United States as well as in India, and we want to make sure we can avoid that. And of course, our fear of COVID is there, but please make a quick assessment of the patient. And as Dr. Shaoliang Chen was saying, that he will feel comfortable if the patient does not have if the patient has a negative test, and if the patient has a negative CT scan, he does take patients to primary PCI in those patients. And as you also heard from all our panelists and Dr. Henry, my co-moderator, that one size does not fit all. Make it just a quick assessment. And Eric, can you show the slide about the increased cardiac arrest calls from Jack as well as the economist? So these are the number of cardiac arrest 911 calls increasing in COVID-19 hotspots in New York City. As you can see, they're much higher in 2020, and also the cardiac arrest deaths were higher. And this is probably, as you know, the mode of death could be cardiac arrest in COVID positive patients, but it is primarily ARDS and respiratory. So we may be missing some patients who ideally would have been treated in a normal procedure, like how we do how we did in 2019 or 18. Tim, anything you want to add on this?
Yeah, and then can you show the slide where the 9 systems and STEMI systems in the United States that showed the decrease? That it's right there. So this is actually, we took 9 systems across the United States, and you can see this is month by month for all 9 systems, and there was a 40% reduction in the number of STEMI activations. And so again, we would have anticipated that there would be increased number of ST elevations, not a decrease. And so then the next slide, we show the increased cardiac arrests. If you notice, even though the COVID deaths started dropping off, that the out-of-hospital cardiac arrests continue to increase. And this was from New York City, where there's a high prevalence of COVID. But this increase in out-of-hospital cardiac arrest has been seen all across the United States. And so could some of those out-of-hospital cardiac arrests be related to COVID? I'm sure some are. There are arrhythmias that happen, and there are patients with COVID that stay home. But I think a good share of this increase is the missing STEMIs, because this same curve has been reproduced all across the United States. And there's also an increase in gallbladders that have ruptured, in abdominal aortic aneurysms that have ruptured, and basically you name it. There has been an increase in deaths because we've dramatically decreased the amount of elective surgery. So patients who've been waiting on TAVR lists, stable coronary disease that had their procedures canceled. So I think this concept of we were worried about overwhelming our hospitals, but what's happened is a large percentage of hospitals in the United States are actually not full at all and are really quite empty. And that's created another profound economic crisis in hospitals in the United States.
So let me ask Parvez, and people who are coming in for STEMI, you think radial or femoral is better? As I know you do a lot of radial procedures as well.
So I think in the end, it's a matter of if you're looking at access site, I think the access site probably, it's more important to make sure you have safe access site technique. And so whether you use femoral or radial, as long as you're doing the right technique, you're probably not going to cause a vascular complication. I'm a big proponent of radial, and I'm sure most people in India are as well, as I know from the past. So there's no reason not to. There's been some thought to say if you place a radial band on the patient, that nurses would have to go and attend to them and be there and maybe potentially get exposed more. But the reality of it is even if you do a femoral procedure and you do a closure device, you're still going to have to attend to the patient and evaluate. And so I don't think there's a difference in that regard. And our nurses, God bless them, they are all in the patient's field and area all the time. And they're definitely not afraid to go and take care of these patients, and I don't think anyone should be. And we just have to find, like we've been talking about, the key is proper protection, do the procedure in the best technique possible. Just because they're COVID doesn't mean you should not do a lesser technique, but we shouldn't do anything that would be above and beyond what we do for any other patient. Looking at like I said, I would use this akin to any other terminal cancer or a brain bleed or something like that, where you wouldn't typically take them to the cath lab. Well, those patients you wouldn't typically take anyway. But the regular average patient who has a good potential quality of life, who's not acutely ill, those patients should be taken to the cath lab. Another piece, Tim, that New York City graph I think is important also to understand is that we have experienced that the New York City EMS system was also very overwhelmed. They were taking hours to respond to calls just because there were so many people calling them for respiratory issues, chest pain, what have you. And so there was a huge delay and it wasn't anyone's fault. It's just the inundation of the whole healthcare system in general.
And I think another point is in hemodynamic instability. When you have already hemodynamic unstable patient, it's good to go for, or at least to have a femoral access ready. If you need any mechanical systemic support, you are ready for that, and you can proceed for angioplasty from radial. I think again, it doesn't make difference femoral or radial. I agree fully. What is you are more comfortable with, do it. If you are more comfortable with radial, go for radial. If you are more comfortable with femoral, go femoral. Just to do it very fast.
Yeah,
as fast as possible.
Right. The distance we maintain from the head of the patient is almost the same. It may be shorter by a few inches. I don't think that makes a huge difference if you have a proper PPE. And some of the questions that came is from Dr. Prasad. After doing primary PCI, do you normally do a PCR test after primary PCI, Shaolian? Please unmute there.
Okay. Yeah. Usually, I think in China, primary PCI was not for all STEMI patients. Particularly, we limited the criteria of PCI only for anterior myocardial infarction or STEM patient with unstable hemodynamics. Another point that I'd like to say is about use of ECMO. So from my database, including 1,037 patients, ECMO was only used in 7 patients. Of them, half died.
So, but you also do the PCR testing after the PCI?
Yes.
Yes. And you actually do it before, right? Or not everyone?
Yeah, right before.
And let me ask you one more question. Do you think there is less incidence of acute MIs in China? Now, some people think it is less air pollution is causing less heart attacks. Is that true?
Oh, thank you. I apologize. I think I did not catch your point before because of the noise. Yeah, actually, the reduction of STEMI patients in China during the virus outbreak was very, very significant. From February to March, in my center, we only had around 25 STEM patients came to hospital. Also, took a consensus in Wuhan city. So from last week of January to the last week of March, only 100 STEMI cases. I think this is very, very similar finding to Italy and also to the United States. I don't know exactly why there is so large reduction in the incidence of STEMI. I think probably it's multifactorial, less pollution, less exercise for patients with unstable plaque, and many reasons, I think.
Yeah, I think also it's multifactorial. Also, the fear to come to the hospital. Many people will die at home without coming to the hospital. There is some confusion of diagnosis sometimes. Death was very high in Italy, and mainly the mean age of death people was 81 years old. And I think among these, of course, the final cause of death was cardiac arrest, and most of these people died at home. And after that, you cannot do any diagnosis, whether it's acute myocardial infarction or not. So, sometimes it's confusing, the final cause of mortality. And I think within this, also, acute myocardial infarction can be one of playing important role in causing mortality among very comorbid, people with more than 1 or 2 comorbidities. And this should be taken in consideration every time.
So let me, before we go into the questions, Eric, could you show that paper by Sripal Bangalore and on the 18 patients? And I want some, it's a very small slide, unfortunately. I'm sorry about that. But people can read. This is actually an 18-case series that was published in NEJM by NYU system. Sripal did that. And let me ask from Parvez first, who also has a probably larger number of series and yet to be published. Parvez, you see that the chest pain is not a common presentation in these patients. Is that right?
No, that's very accurate, actually. So the presentation, Sripal's paper actually pretty accurately describes what I think all of us in the region were seeing. The majority of these patients are coming in not with your typical symptoms. They're not coming in with dyspnea and exertion. They're not coming in with acute onset chest pain. They're coming in with more atypical symptoms, and a lot of their EKGs, and many of these patients' EKGs are representative of the STEMI cohort. And in a typical time, you would take all these patients to the Cath Lab. It remains interesting as to why so few of these patients had chest pain. But the one thing was that the one differentiating clinical story is that as we took care of more of these patients, we were able to discern there was definitely a difference between the true ACS patient, albeit COVID positive, and the not true ACS patient that was COVID positive, not looking at their EKG. the presentation, the story, their symptoms, the subjective measures that you would use to sometimes evaluate these patients to determine how ill they are, you would determine that their respiratory illness was more severe than their chest pain illness, albeit the EKG and the enzymes and everything else would suggest ACS. And that's there are nuances. However, the nuances you can't put in a table and you can't put in an algorithm. But these are the findings. But the findings were relatively accurate.
And majority of them died. Mortality is much higher, right?
They saw that, and we saw that as well. The numbers are very similar. Probably upwards of 60 to 70% of the STEMI patients that we saw had mortality, which is unbelievable because we've never seen that kind of mortality in a STEMI population before.
Right. Yes. Yeah.
But that is because overlapping, of two diseases.
Yes.
Yeah.
Correct.
Yeah. Do you think that the delayed, as Tim is saying, and Tim jump in, delayed presentation, delayed care, or lack of mechanical circulatory support in timely fashion is caused, all this is because of lack of symptoms, atypical symptoms, right? And is that playing a role?
Yeah, I think it is. I think what we're going to see is just already, so what we have done with SCAI and the Canadian Interventional Society is we've put together a registry called the North American COVID MI Registry. So it's a very nice cooperation between in North America. But clearly already I can tell you that the overall, if you look at COVID negative patients, the mortality has increased substantially, and a lot of it is late presentations, and for sure. And we're not getting all those patients because I think they're definitely a percentage of the out-of-hospital cardiac arrest increase is clearly is STEMI. So I think if you look at this in terms of lessons learned, over the last 20 years, we've made tremendous advances in the treatment of STEMI, non-STEMI, and coronary disease. And we have to not forget that. We have to not forget that. And we have to encourage patients to come to the hospital. We have to take care of them as best we can. We have to do it with good PPE. So I think when we, after I think a lot of places in the United States, the numbers are decreasing, including New York and New Jersey. And I think it's really important for us to look at this data very carefully, to be thoughtful about this, and to have lessons learned. But I think part of that lesson learned is we know how to take good care of patients, and we should try to keep doing that even in the midst of a pandemic as best as possible, with keeping your healthcare workers safe. And I think as long as you're prepared and you have good PPE, you can keep your health workers safe. It's when the system gets overwhelmed that you have the trouble.
Yes. Several of our audience, we had more than 950 attendees, and I think several of them have asked, should we start wearing PPE from the car park of the hospital? Absolutely. I think if you're coming into a hotspot area, which is such as Mumbai or Hyderabad or Chennai, please wear, or any big cities, wear a mask when you go out. In New York State, it is a mandate by the governor that everybody should be wearing a mask. So let's go to questions. We have few questions that we wrote that were given to us earlier, but we'll address all the questions that are coming through as well. Eric, question number 1. In the meantime, I'll ask, here. This is a great question for everyone by Ram Mohan Bhatta and the Shabi Satpathy. Both of them have asked the same question. Prophylaxis by hydroxychloroquine, is it a myth or a magic pill? Let me start with Parvez.
Well, we have a trial going on in Detroit that's going to hopefully help us. I think Henry Ford is doing this, if I'm not wrong, looking for healthcare workers in prophylaxis with hydroxychloroquine. I have not anecdotally been impressed with the effects of hydroxychloroquine in the patients that we've been treating patients with prophylaxis. We have not done it, so I cannot give you objective information on that.
Okay. Shaolian? I think you're muted again. So I'll come back to you. Please unmute your phone. I'm Imad. Do you think a physician should get prophylaxis with the hydroxychloroquine?
Well, actually, we do not have that much numbers to say something supported by scientifically or by experience. Most of positive patients are not directly treated by us after any procedure. They will COVID section and will be followed by the infectivology doctors. I mean, so I do not have any experience to say to support or not to support this.
Yeah, Charlene.
Oh, thank you. I think prophylaxis is very, very important for any hospital before any intervention. You know, since at the very early stage of epidemic in Wuhan, so all China hospital have our own protocol how to prevent the medical staff also to protect the patient too. So I think this is very important. For example, in my hospital, so from the very early February, my hospital has our own protocol to educate, to train our employees how to protect us.
Good, very good. So next, let's go to the next question.
Can I just really weigh in just one quick about therapies overall? So number one, for HCQ and chloroquine, our infectious disease, first of all, there's some small studies that show some benefit. There's some studies that show less benefit. And I would encourage everyone that what we need for therapies, whether it's antiviral agents, it's vaccines, the immunomodulators, there's a whole number of clinical trials that are actually ongoing. And what we really need to do is, as best as possible, have randomized trials that look at it. And in the meantime, I would say that, from our infectious disease people that look at this, that if there is a benefit with the HCQ, it's earlier on in the symptoms. Whether prophylaxis works or not, I don't think we know, but there's several good trials that are actually underway. So we'll hopefully have an answer of that before the fall. If there is positive, it's early on in the symptoms before you get hospitalized. I think certainly patients who are intubated and farther along in their disease, there's probably limited data at all that it works there. But I think all of these therapies, what I would encourage people is we need to do well-done clinical trials so that, I think many of us believe that COVID will be back and that this is going to happen again. And we need to develop therapies that we are effective based on clinical trials.
Yeah, actually there is many proposal cocktails or so many, more than one treatment. And until we do not have good collection of data by randomized trials, I think we cannot do any, we cannot come to any conclusion at this side.
Yeah, that is the only way that we can differentiate ourselves from as physicians and people who are of a scientific knowledge than the general public.
Absolutely.
The answer from Dr. Shahabuddin is there's no which antiretroviral treatment may be effective. Right now, as we said, there is nothing working for this virus. Next slide, please, of questions. Eric? So, question by Muhammad Ali, Ratinder Pal Singh, and Jean. So in COVID, probable, a person under investigation is probable. Who presents with a STEMI? What is the best approach? And this question has been asked by many other as well. We have mentioned that in areas which are PCI capable, taking them to the Cath Lab is better. In places where it is not, there's no PCI capable, or you have only single lab, and in between you have to terminally clean. And in the meantime, that if a patient comes in, I don't think that there is anything wrong with giving fibrinolysis in this patient. And as we said, that there is an increased mortality from this case series of COVID patients, but that doesn't mean that we should not actually take the patient to the Cath Lab. a COVID PUI, person under investigation patient, might become negative later. So please do not delay the treatment in appropriate patients. It could be one of our family members as well. And I know that I think someone in Navi Mumbai also passed away because of delay in treatment. The question, next question, please. Let's look at that. And from Vaibhav Dedi in Mumbai, he's asking, when do you see normalcy returning? Yeah, keep this slide on. How long will it? We have to follow these protective measures. Shaoliang, let me ask you. You probably have the most experience, and I'm talking about SARS-CoV-1 in 2003. And how long has it taken with the SARS-CoV-2 to return to normalcy in Nanjing?
Yeah, actually, the first case happened on February 2,
January.
I think. Pardon me?
Not January, February.
Yeah, February 2. We had our first case, and in Nanjing, we only have 93 confirmed COVID-19 positive cases, a very small number in China, I think. So the last case was in the March 10, I think. So after that, so we started to go back our normal life from March 28.
So there is a resurgence, and from Nishit Chandra from Mumbai, he's asking again. India has done quite a great job in trying to flatten the curve by a complete national lockdown of 1.3 billion people. And what is our take-home message for Indian cardiologists once we reach the peak? When they really, how would you allocate the resources? I know there's a lot of allocation of resources in cardiologists in New York. Parvez, when we reach the peak, how do we adjust our duty hours?
It's a really good question. We're in the middle of trying to figure that out right now. Yeah. So we pretty much just, I think, hit our peak or just reached our peak just a little while ago, albeit I think every center is different. I think this is the conversation is not a general conversation for the whole country. And I think even for our own health system, we're a health system of 27 hospitals. And because our smaller hospitals were more inundated, we have been taking the transfers to our larger center because we have more capacity. So albeit the peak may have been reached in New York, we have as an institution have not really reached our peak. We're sort of kept at that peak. And we've been keeping ourselves at that level. And so just as a general conversation, we've been having the conversation. I'd love to hear what Imad and Shaolin have to say about this as well. But once we reach our peak, once our hospitals start to decant, once we get our recovery room back, because even our Cath Lab area, the entire Cath Lab recovery and short stay areas have become COVID ICUs. So obviously, until those areas are not freed up, it's going to be very hard for us to even think about starting some normalcy. We have all been deployed to taking care of patients in the ICU, and as the ICU the numbers start decreasing, we will be taken back out of the ICUs. That is yet to happen, but it will happen hopefully soon. So we are by no means ready to start coming back to a level of normalcy. But I would certainly believe that the first step would have to be bringing your areas back online, keeping them areas clean, giving the patients a sense of safety, where they feel like they can come back to the hospital for elective procedures and not get COVID. So areas that are truly COVID free. So I think that's the most important thing.
The next question is how to manage DIC and STEMI. Tim?
Say it again. How to
manage DIC and a STEMI patient in COVID?
DIC with DIC?
With DIC.
It hasn't come up for me. Have you?
No, we haven't seen a DIC patient in STEMI. We've taken care of DIC patients in the ICUs. Obviously, there are some patients that develop DIC in the ICUs, and obviously you treat them as you treat any DIC patient. But the reality of it is that once they reach the point of DIC, as Shaolin mentioned in a message to all of us, it's beyond recoverable. And I think the goal of this is to try to mitigate that cytokine storm with renal replacement therapy or what have you. There has to be some mechanism there where you avoid that outcome, because once you reach that outcome, if someone presented me with a STEMI EKG and someone who's intubated with COVID pneumonia and DIC, that's the kind of patient I would not take to the cath lab.
And can I just make a comment about the starting? And I think that if we look at some lessons learned about this, in the United States, we really pretty much shut down elective all across the whole United States. And I think, and part of that was a concern that did we have enough PPE? Part of that was a concern. We didn't want to overwhelm the hospitals. I think Northern Italy and New York and New Jersey scared people. But I also think there's consequences of that. So there's been profound effects on the healthcare system in the United States. Many healthcare systems have laid off people, have cut salaries. And so I think what you have to do is if you're in a part of the world that this hasn't, you have to be thoughtful. You have to be prepared with PPE and be prepared to have areas of your hospital that can be COVID and areas that are not. And then I think you have to be thoughtful about how much you really dial back that. Because I think many places in the United States that didn't have as much COVID, it may be that the cure was more dangerous than the disease because of this concept where we scared patients to death, literally, from coming to the hospital. And then I think this issue about opening up again and how we do it, again, you have to do it thoughtfully. And it's very regional dependent. It's very hospital system dependent. And I think people need to think about how you're going to do it. You need to make patients feel safe again. And so have COVID-related areas, safe areas. I think as we do more testing and we have a really better idea of how many people are truly infected, it's like several just in the last days have come out that a lot more people have probably been exposed and we're relatively asymptomatic. So that's a good standpoint from that we've increased herd immunity, but it's also one of the reasons why it spreads because a lot of patients are asymptomatic. So all of these things, I think the best thing that we can say for people on the phone or on the webinar today is we aren't done learning. There is a whole host of information that we need to do. And I think it's really important that we do good clinical trials. We look at the data that we have and be thoughtful about this because I think COVID is with us to stay for a long time and we have to learn how to deal with it.
Yeah, I totally agree. I think work in progress. We do not have that much knowledge about what is the virus doing. I mean, in terms of immunity also, whether it is giving persistent immunity for patients who came in touch with the virus, I mean, have been infected or positive or not. Which kind of immunity, we do not know. So I think, yeah, we should collect more and more data, from clinical trials, good conducted trials, and then we have to learn much more about this virus because I am sure that this virus will stay with us for a long time, and I think we will never be completely free of this virus. Then I think that it is very essential to learn more and more, and to be to have more defense against this virus. That means vaccines or therapies, and this is coming only from good supported clinical data.
I think it makes it even more important that, when we start reopening everything, as Tim and Imad and Shaolin and everybody's been saying, you as well, we have to test everyone that comes in. We have to make sure we have the ability to test patients so we know who's positive and who's not, to be able to secure and safely take care of patients and staff and everybody else. As everyone's saying, I think we all agree this virus is not leaving us anytime soon. So we have to be prepared for all the inevitabilities and taking care of these patients. We cannot shut the whole health system down because of the virus, but we have to find a way to most effectively and safely take care of our patients in the midst of all this.
Yes, very important. I actually, the people who are asking lots of questions, I don't know whether we could extend our time, but we all have to be safe. We need to make sure we have enough PPE. We need to make sure we actually clean this entire room. So if you see my room, it's practically, there is nothing which is really hanging on the walls or anything, because this is now a clean room. Rather than having many things, it is always easier to clean. And if you really need to attend to the patients, I would make sure it is not in my private chamber. It is in a designated area where it is terminally cleaned at the end of each patient and before another patient is brought up. So there are lots of questions, and I'll tell you quickly. Let me answer as much as possible, and please jump in. And when there is a patient who is in need of a temporary pacemaker or a balloon pump, our hospital policy is actually to do it at bedside. And if they really need to go into the lab, obviously, if they're stable, we take them to the Cath Lab with a face mask on the patient. And as Tim said, a limited number of people in the Cath Lab. Everybody is wearing PPE, at least category 2, as much as in our 2 masks, 2 pairs of boots, and 2 pairs of clothing over their scrubs, and then the shield, our apron, lead apron, and then a gown. And while if the patient is unstable, we intubate the patient in a negative pressure room before bringing the patient into the Cath Lab, just because if they're unstable, they can cough and aerosolize the whole area. That is going to be putting healthcare workers at much higher risk. And when they are brought into the Cath Lab, the whole corridor and everything is blocked off, and the security guards will stand there and make sure that patients are being brought in such a way. But that is our policy. But in New York, where Pervez is, everybody is infected, so I don't think that you can follow. Right, Pervez, is there any difference that you do now versus you did it in the past in terms of taking care of a patient with the STEMI?
No, I mean, I think there's a patient who presents to the hospital with a STEMI EKG, whether they be COVID positive or negative, as long as they're not critically ill from their coronavirus disease, they're treated the same way. Irrespective of their because we're not going to get the test back soon enough, so everybody's treated with everyone's taking PPE precautions. They're taken to the Cath Lab. Everything's done the same way. The 2 patients are not treated any differently. The only time that you treat the patient differently is if they're not presenting to their ER with a STEMI EKG. They're in the hospital. They're already in the midst of their COVID illness. They're have acute respiratory illness, and they develop a STEMI EKG later in their course. That's a very different patient than someone who presents with a STEMI initially in the ER. And that's I think a very and if you actually took those 2 sets of patients, even in Shripal's paper and even in our upcoming paper, you'll see that those 2 patients have completely different outcomes. And that's because of one is in their acute respiratory disease syndrome, and that patient's probably not going to do well no matter what you do. But the person who presents and is not in an ARDS and doesn't have severe hypoxia, that person you're treating the same way. And I think that's the most important thing to take away from this, is that it's not the patient that's in your hospital that's been intubated for a week that develops a STEMI EKG, that's the patient that we're all worried about. I think it's the patient coming from home that has de novo STEMI symptoms and ischemic EKG changes with a good story. That's the patient that we don't want to miss. And I think that's the most important thing.
Yeah.
So the next question is for Xiaoliang. I think you have some experience with Flavipur. Dr. Chan Singh is asking about your experience.
Yes, thank you very much. Because, since the initialization of COVID-19 in Wuhan, so different teams have designed different clinical trials to compare different antiviral agents for severe and very critical cases. But so far, I don't have the final results from those randomized clinical trial. But I do have my last database to including different kind of antiviral agent for patients. So far, there is a very, very clear trend to support the routine use of antiviral agent, particularly arbitol and flavivir. In Nanjing, we only use this drug for 24 severe patients. But in Nanjing there was no days, so I cannot conclude which antiviral drug will be much better than any others. So probably we still need a randomized trial. Thank you.
Thank you very much. And I think, Tim, you might have to leave. If you have to leave, thank you very much for our moderator, Dr. Timothy Henry from Christ Hospital in Ohio, for joining us. And please stay on as long as you want, Tim. I think our colleagues, I'm receiving very positive response from our Indian colleagues that they really enjoyed our webinar.
No, I will just say thank you for being here. I've enjoyed it. I actually have to go to clinic and see patients, so but I really appreciate it. And I hopefully in India that it seems as though you haven't been overwhelmed yet. I hope it stays that way. And this was fun for me to get lessons from around the world. So Maud, Shaolin, Pervez, thank you very much. And Ramesh, thank you for all that you do. All right.
Thank you very much. We'll continue for another 9 minutes.
Thank you. Thank you.
All right, bye.
Thank you.
So, treatment of ACS and STEMI. Let me ask you quickly: the reperfusion strategies should they be different for different areas? Shaolian, you can start, and I'll come to Imad and then Parvez.
Yeah, I think it should be different. In general, I prefer to recommend a fibrinolysis for very stable stem patient, particularly for inferior wall myocardial infarction. But for most of anterior wall myocardial infarction or STEMI with unstable hemodynamics, I think PPCI should be the primary treatment for such kind of patient. For a non-STEMI patient with unstable hemodynamics, I also recommend to use PCI for them. Thank you.
Thank you. Imad? Parvez?
So I think the regional differences in STEMI treatment, I think definitely will exist. I think there are a lot of factors. We wrestled with using thrombolysis as an initial strategy, and I think because our Cath Lab was not overwhelmed, we opted to not go down that strategy, and we were able to take people to the Cath Lab appropriately screened. But I think the bigger issue, I think, is one, patients are clearly not coming to the hospital with their acute coronary syndrome symptoms, and I think that's the biggest piece and the biggest difficulty. Because had we had the full onslaught of ACS that we should have seen in the current scenario, maybe our treatment strategy would have changed. But because our numbers were so low, we were able to take care of all of our patients with primary PCI that we felt deemed appropriate. But I think the strategy can be what Shaolin said. I think it's a completely appropriate strategy, and I think everyone has to look at their own individual strategy and decide whether or not their systems are being overwhelmed, whether the systems of care can handle it. And if their systems can handle it, if they have the appropriate PPE, then they should proceed. If they don't have the appropriate PPE or the systems are going to be overwhelmed, then I think we have to start looking for alternative options in terms of the treatment of ACS.
Okay, in my area, we have a dedicated network for primary angioplasty for all patients. That means all facilities with 24-hour services will be connected to the same center, and all patients are directed to the nearest hospital for PCI, for primary PCI. So this is what's normally done. But nowadays, I mean, there are multifactorial delay for the primary PCA. That means from chest pain to first emergency contact, and then door to balloon or to device time. All these can be increased when you should take your precautions for PPE, not only for operator but for all the staff in the Cath Lab. And this can modify at least in some patient the strategy and start to use in some patient at least thrombolysis. But again, you should take in consideration the contraindication for thrombolysis exists as well. Indication coming from guidelines, all guidelines giving more efficacy for PCI. So all these factors will support you in continuing doing PCI whenever it's possible. But again, I will underline that PPE is essential in every patient you are doing your cath lab. So if you have a viability for PPE, then go ahead with PCI as first option. And if you don't have a viability, then I think you should select patients, those who are with high possibility to be exposed for COVID. I think they should go for thrombolysis.
Very good. So let me ask you about myocarditis and COVID. Is this a hype that we said and we don't see that much, or do we really see it often? Or where you can start?
Oh, no, we're actually, interestingly enough, our very first case of STEMI in the COVID era was a myocarditis patient. So it's definitely a true entity. It may not be the traditional viral myocarditis that we would see in the old days. I'd like to call the pre-COVID era days. But I think that there is definitely myocarditis. There's definitely myocardial injury, whether it's due to direct viral injury or due to the inflammatory markers or due to the stress myopathy that may be caused by some of this. It's a little unclear as to the understanding of it. And I think maybe Shaolin and Ahmad can chip in on exactly what they've seen. But it's a true entity, and it's what concerns, I think, many of us for giving thrombolysis in these patients, because obviously giving thrombolysis in a myocarditis patient isn't exactly the ideal option.
So that is the reason that we are saying that probably those patients who have high troponins and high BNP should be actually taken to the cath lab so that we don't inappropriately treat with lytics as well. So that's some concern that we have. And Imad, let me ask you about D-dimers and anticoagulation. Are you using a lot of heparin or enoxaparin?
No, actually, we are using the normal dosage of heparin in patient coming for ACS in general.
Meanwhile, while you said somebody asked how long is it going to be, this is going to be a long, right, Shaoliang, that this pandemic is not going to go away very soon. As we said, that it is going to be there for at least resurgence in maybe another couple of months. It will come back. We are going to prepare ourselves. Somebody asked, if you're having a single clinic, what is going to happen? Obviously, people are losing their jobs, or we are taking our pay cuts. Actually, we offered, because some of our medical assistants and nurses don't lose their jobs. From all top-down CEO and all the executives, all of us are taking some pay cuts. So this is unfortunately that's going to happen. After PCI, what we do is every patient who is entering into the cath lab, we keep a log of all the patients, and they are going to be tested. They are quarantined. So we have to be very careful. If a patient becomes positive, go back to contact tracing and isolate them and follow the usual protocol to keep them quarantined for about 2 weeks, and then they're brought back to the hospital.
Just to show you, it was just to show you a case of myocarditis complicated by ventricular fibrillation at home, and he came to the hospital and arrived, of course, late because he was just 25 minutes after cardiac arrest at home. The message was the cardiac massage was performed by his son. And then in the medical emergency medical service was coming and with the patient to the hospital, and echo showing hypokinesia, ejection fraction less than 35, and normal coronary arteries. The problem in this patient that he was resuscitated, but brain damage was there because of the delay in resuscitation. monovirus. So this is another problem also faced by some of cardiovascular complication of COVID that occur at home, and it is not easy to reach the hospital, particularly in this in the arrhythmias patient, to reach the hospital in time and with avoiding the cerebral damage in these patients. So this is another point I think to keep in mind.
Yes, I think that is the crucial part of the messages that unless you take them to the cath lab, we will not know whether they are truly having myocarditis or occlusive disease. Of course, we can use imaging and other modalities if you want to see the severity of the blockage. But if they have occlusive disease, then it is treated with the primary PCI. If they do not have occlusive disease and they have TME3 flow, I think you can still manage them medically.
Yeah, actually, I think neurologists can be a multidisciplinary evaluation whether to do or not to do and what to do in these patients. It is essential because they can give you at least an idea about the recovery, the possible recovery of the patient from not only from cardiovascular point of view, but also from let's say brain, cerebral point of view. So neurologists, I think, is very important in patient arrested and come to the hospital to be intubated and then should be evaluated before going to the cath lab, should be evaluated by neurologists, by cardiologists, and evaluating the risk benefit in this patient to do any invasive procedure.
Shaoliang, we have any? We have 1 minute and a short message for the audience.
Yeah, thank you very much, Ramesh. I think now is the conclusion part. I just want to say, during the epidemic, the differentiation of type 1 myocardial infarction from type 2 MI from the myocardial injury is very, very difficult, and it's very important. From my database of more than 1,000 cases with confirmed COVID-19 patients, there were only 4 type 1 myocardial infarction. Both are STEMI patients, but unfortunately, they were misdiagnosed and mistreated. So finally, they died in the next 2-3 days. I think this is very important. But my finding is that for COVID-19 positive patients with STEMI, the increase of the troponin I is not as high as the patient with the COVID-19 positive with very severe inflammatory storm. So this is the first point I'd like to say. Second thing, I think the selection of different strategy should be dependent of the individual places, individual hospital with different capacity. I think this is very important. But in general, I do believe the primary PCI should be the primary treatment priority of the STEMI patient, whatever this is stability of the hemodynamics. Thank you, Ramesh.
Thank you very much, Shaoliang. And Pervez?
No, I agree. I think this has been a great experience, and I hope everyone in India appreciates the diversity that we've all been talking about, and the divergence in the exposures. And I'm sure you're in India, we're going to see the same thing. I don't think it's going to be very different. Every country is going to have a slightly different exposure and risk rates and mitigation strategies. But the most important thing I think I can say is we should make sure that we're doing right by our patients. And I think that we have to protect ourselves and our staff and everybody that's around us, very important. But we must take care of these patients because as we all know, I may be the most junior person here, and I appreciate all my senior mentors and colleagues over the last 30 years of where we've taken primary PCI therapies and strategies. And we shouldn't lose sight of that benefit in the setting of a pandemic, and we have to find the most appropriate, safe way to take care of these patients. And I think that's the most important thing. So we should all work together as a community to find that strategy. And I think one thing is for sure, if there's any silver lining here, is that we across the world have really come back together to get our data, get our experiences together, and really learn from each other in a way that I don't remember having seen this kind of collegiality and collaboration in a long time. So it's a pleasure to be part of it.
So thank you very much on behalf of Society of Coronary Angiography and Intervention. We would love to work with the Cardiological Society of India of different chapters to have a registry in India, to learn from each other. And we are always here for any questions. I'm on WhatsApp, and as well, please reach to us so that we can address some issues you may have. And unfortunately, I may not have been able to answer all the questions that we had, but I tried to do as much as a good job to probably cover everything. And I want to thank Sun Pharma for the sponsoring this program, and for my co-moderator, Dr. Tim Henry, and our panelists, Dr. Xiaoliang Chen from Nanjing, Dr. Imad Shaiban from Italy, and Dr. Pervez Miraj from Northwell, New York. Thank you very much for joining us.